Hello, everybody. Welcome to the second module. I'm Dr. Nuntusowa Majosi. I'm a district clinical specialist pediatrician currently based at Harigwara Health District, which is one of the districts in KwaZulu-Natal. I will be taking you through Module 2 of the ETAT training course, which is all about assessment and management of airway and breathing problems. But before we get into Module 2, let's do a quick recap of what we learned in Triage. So by now we're aware that we've got emergency signs and we've got priority signs. We remember our emergency signs by the acronym A, B, C, 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 D, which are problems related to airway, breathing, circulation, coma, convulsions, and dehydration. These are our patients that need to be managed as a matter of urgency. And then we have our priority signs, which we remember by the acronym 3TPR, MOB. The 3 T's stands for tiny baby, which is a baby less than 3 months of age or less than 5 kgs. Temperature is a patient with hyper or hypothermia. And T, the third T stands for our trauma patients. Then we also have our 3 P's, which stands for severe pallor, poisoning, and severe pain. The 3 R's stands for respiratory distress. This would be mild or moderate respiratory distress, a restless patient, and an patient that is referred as an urgent referral. And our MOBI stands for malnutrition, edema, burns, and impaired circulation. These are the patients that go to the front of the queue. So airway and breathing problems are potentially life-threatening. If you cannot breathe or you're struggling to breathe, that is a risk to your life. So these particular patients need to be managed immediately before you do the rest of the systems exam. Right up front, try and figure out if there is any possibility of head or neck trauma, as this affects how you will assess the airway and the breathing and your further management. By the end of this module, you should be able to assess the airway, manage airway problems, assess breathing, manage breathing problems, and manage the choking child. So when we assess the airway, there's certain questions that we need to ask ourselves. And if we find that these questions are present or the answer is positive, we need to move the patient immediately to the resuscitation area and manage further. So these questions are: is the patient breathing? Is the airway obstructed? Is the patient blue or cyanosed? Does the patient have severe respiratory distress? Any of these need immediate management. So how do we assess if the child is breathing? Well, if the child is talking or the child is crying, then that child is breathing. However, if they're not doing any of these things, then we need to look, listen, and feel. We expose the patient's chest and we do these assessments at the same time. So while we look to see if there's any chest rise, at the same time you are listening for any breath sounds, and at the same time we are feeling for any movement of air against our ear or against our cheek. We also assess if there's any noisy breathing. Noisy breathing could indicate an obstructed airway. Now, the obstruction can be caused by fluid in the pharynx, whether this be vomitus or blood or saliva. It could be from the tongue. So in patients with a depressed level of consciousness, the tongue can flop backwards into the airway and cause obstruction. It could be from a foreign body, whether this be food or beads or toys that the patient has put into his mouth, or from infections like croup. We do have to keep in mind though if the airway is severely or completely obstructed and there's no airflow, then there won't be any noisy breathing. Is the central cyanosis. Central cyanosis we see with a bluish or purplish discoloration of the tongue or the insides of the mouth and skin. And this indicates decreased oxygen saturation. It is also important though to keep in mind that in a patient with anemia, this clinical sign may be either very difficult to see or delayed. Does the child have severe respiratory distress? So the signs of severe respiratory distress that we look for are very fast breathing, severe lower chest wall indrawing, grunting, head nodding, cyanosis, inability to feed, and exhaustion. You will be seeing some videos on some of these clinical signs later on in this slideshow. So again, this is a reminder that if, as you're assessing the patient, if you find that any of these signs are positive, you stop the assessment at that stage and you take the patient immediately to the resuscitation area and you manage the challenge or the problem that you have picked up. So once you've taken the patient to the resuscitation area, what exactly is the management that you can institute? Firstly, by now you should have made a decision of whether or not there is a possibility of head or neck trauma. This, of course, will be based on history and your clinical findings. For instance, if you see bruises or lacerations or broken bones and things like that, you should be on high alert that there is a possibility of head or neck trauma. However, if there's no possibility of head or neck trauma, then the first thing you want to do is to open the airway. You want to open the airway, you want to be able to look inside, you want to be able to remove any foreign bodies that you can see. So how you open the airway, if there's no head or neck trauma, we do the head tilt chin lift maneuver. If the child is less than 1 year of age, you're going to tilt the head backwards so that the nose is pointing directly upwards. If the child is older than that, then you're going to tilt the head backwards so that the chin is pointing upwards. This is to do with the changing anatomy and the movement of the airways as the child grows. If there is a possibility of head or neck trauma, then we don't do the head tilt chin lift because we want to keep the neck as immobile as possible. Instead, to open the mouth, we do the jaw thrust technique. And the way we do this, first of all, you would place your hands on the patient's face with the base of your thumbs on their cheekbones on either side. Then using 2 to 3 fingers at the angle of the jaw on either side, you're going to thrust the jaw upwards. Once you've done that, you can use your thumbs to open the mouth. You will need an assistant to remove any foreign body or to suction for you because your primary responsibility will be to make sure that the neck remains immobile. If there is a possibility of head or neck trauma, we want to immobilize the neck as much as possible. And the way we do this, we can put either head blocks or vacuolators or sandbags on either side of the patient's neck, patient's head. Then we strap this down to a spine board. Please do not strap onto the patient's bed. You can strap onto the spine board, but not onto the patient's bed. Also, please do not use soft collars as a means of immobilizing the neck because it does not work. If you need to turn that particular patient for any reason, whether it be to examine the back or to move the patient from one bed to another, then you need to use the log roll technique, which ensures that the head and neck and spine remain aligned at all times while the patient is being turned. Once you've opened the mouth, you look into the mouth. If there's any visible foreign bodies, you remove these. And if there's any secretions, you can suction these either with a hard suction catheter or with a soft suction catheter. Then you go back and you reassess if your maneuvers have worked. And how you're going to reassess that is to look, listen, and feel. So look for chest rise, listen for breath sounds, feel for any air against your ear. Right, now that we've opened the airway, we need to manage any breathing problems. So if the patient is not breathing or has obstructed breathing, you've opened the airway, you've done a head tilt, chin lift if there's no neck trauma, or you've done a jaw thrust if there is neck trauma. You've removed any foreign bodies, you've suctioned the airways, but the patient is still not breathing. That patient needs to be assisted with breathing, and we're going to assist this patient using a bag and mask. So when we've made that decision to use a bag and mask to assist with manual ventilation, we need to ensure that we're using the right size bag and mask for this patient. You need to use a bag that's big enough to cause adequate chest rise without causing over distension of the chest. And in a neonate, you use a bag that's about 250 mils. Infants and small children, 500 mils, and older children, 1,500 mils. Just as it is important to choose the right size bag for manual ventilation, it is also important to choose the right size mask. So you want a mask that's going to cover both the nose and the mouth. You need to make sure that it is not protruding below the chin, and you need to make sure that it's not excluding the nose, and you need to make sure that it's not so big that it's causing pressure onto the eyes. So picture number 1 would be the appropriate size mask. It may be necessary to insert an OP airway. So generally we would use an OP airway in patients with a depressed level of consciousness. However, before you insert the OP airway, you also need to measure it because they also come in different sizes, and you need to make sure you choose the appropriate size OP airway. So how we measure this, we measure using the OP airways from the middle of the mouth to the angle of the jaw with the OP airway facing the patient as demonstrated in this picture. And then once you've chosen the right size OP airway, then you can insert it into the mouth the same direction as it sits in the mouth. So there's no need to be rotating the OP airway once inside the mouth. Once you've chosen all these things, you can then manually ventilate the patient. So what do you do if the patient is breathing but has central cyanosis or hypoxia? In this case, then you need to supplement the patient with oxygen, and we've got different options for oxygen supplementation. In an emergency situation, you will preferably use the non-rebreather mask. This is the mask that comes with a reservoir bag. We generally run these with flow rates from between 10 and 15 liters per minute per liter, and that gives us an FiO2 of between 60 and 90% FiO2. Then as the patient stabilizes, you can wean the oxygen or change to a different modality. We also have the option of Venturi masks. Now, Venturi masks look similar to the non-rebreather mask, however, they don't have the reservoir bag. They just have the corrugated oxygen tubing over there instead of the reservoir bag. Now, the important thing to remember about Venturi masks, they can give an FiO2 between 28 and 60%, and it depends on the color mask that you use. It's not important to remember which color gives you how much FiO2, because if you look at the bottom of the corrugated tubing, it will tell you what flow rate you need to use for that mask and how much FiO2 it may be able to deliver. Another modality that we have at our disposal is the nasal prongs. These are prongs that go straight into the nostrils, and we usually use flow rate of between 0.5 to 2 liters depending on the patient's age, and they give us an FiO2 of between 30 and 35%. Another way of administering oxygen, which may be available in some facilities, is by use of high flow humidified nasal prongs. Now, these are specialized kind of prongs which are attached to a humidifier which can heat and humidify the oxygen that is delivered to the patient. This also allows us to deliver flow rates of higher than 2 liters per minute safely to the patient. Please have a look at the oxygen videos slideshow, which is attached to this course, which gives further information on oxygen delivery systems. Right, now when we get to the choking child. So if you have a patient that's choking, first of all, we need to assess if there is a cough. If the patient is coughing, is the cough effective? If they've got good tidal volumes, they've got a good cough, then we let them cough. This is the most effective mode of relieving the obstruction. We encourage them to cough, we support them, and we continually reassess. However, if they're struggling to cough, if they can't catch a breath between the cough, if they can't talk, we are worried about an ineffective cough, then in that case, we have to decide if the patient is conscious or if the patient is unconscious. In the conscious patient, then we can start with interventions of 5 back blows alternating with 5 chest thrusts or abdominal thrusts. We repeat this until either the obstruction is relieved or the patient loses consciousness. If the patient loses consciousness or is unconscious at the beginning, then we open the airway, we give 5 rescue breaths, and we proceed with the CPR protocol. So if the patient has got an ineffective cough and they're still conscious, the infant that's less than 1 year of age, you can place on your lap, head down, facing down with the head lower than the rest of the body, and you give 5 back slabs between the scapula. If that doesn't help to relieve the obstruction, you can turn the patient over, still with the head lower than the rest of the body, and with 2 fingers just above the xiphisternum, you give 5 chest thrusts with a 1/3 diameter of the patient's chest. And then you just keep alternating these maneuvers of 5 back slabs or 5 chest thrusts until either the obstruction is relieved or the patient loses consciousness, in which case you proceed to CPR. If it is an older child, you can still give them 5 back slabs. You can straddle them across your lap, or you can have them standing or sitting, and you still give 5 back slabs between the scapula. If that doesn't relieve the obstruction, then you can do the Heimlich maneuver, where you go behind the patient. You do a fist with one of your hands, and you place that fist in the epigastrum just below the xiphisternum, and then with your other hand you cover your fist, and then you pull inwards and upwards to try and dislodge the foreign body. You do that 5 times, and if that doesn't dislodge the foreign body, then you go back to back slabs, then you alternate between back slabs and Heimlich maneuver until either the foreign body is removed or the patient loses consciousness, in which case you proceed to CPR. Now we're going to take a look at a few videos which demonstrate some of the clinical features that we spoke about in the slideshow. This is a video demonstrating a patient with central cyanosis. So if you look at the inside of his lips, you can see that they're looking a little bit bluish purple. That is a sign of central cyanosis. In this video, you can also see that it's got another sign which we call ala flaring, which is that movement of the nares inwards and outwards. This patient has also got central cyanosis, as we can see, blue tongue, blue lips.
A child not able to drink or breastfeed includes the child who is too weak to suck or swallow. This child is not able to drink.
This video demonstrates a patient with very fast breathing, but he also has another sign which we spoke about, which is chest wall indrawing. In this case, in particular, subcostal recessions. This patient has got severe chest wall indrawing, as well as some intercostal recessions. But if you look at him, you can also see that he looks quite tired. This is a very sick baby with severe respiratory distress. This patient also has some chest wall indrawing with subcostal recessions and intercostal recessions. This one also has some sternal recessions and subcostal recessions. This is a very common sign in premature babies where it almost sounds like they're crying, but as you can see, this little whimpering helps to keep their lungs open. This patient has got severe respiratory distress with chest wall indrawing, tachypnea, and if you look at him, he also looks quite lethargic. This is a very sick baby. we've seen this video before of a patient with stridor, but if you look closely, he's also got respiratory distress. So in summary, what we've learned in this module, to assess the airway and breathing, we need to ask ourselves a few questions. Is the child breathing? Is the airway obstructed? Is the child blue? Are there signs of severe respiratory distress? These are indications for us to take the patient straight into the resuscitation area and to manage further. Is there a history or signs of neck trauma? This helps us to adjust our management accordingly to protect the neck. If the patient is not breathing, then we need to open the airway, remove any visible foreign bodies, and ventilate with the bag and mask. In all cases, the highest concentration of oxygen should be used first in an emergency, in which case there will be a face mask with a reservoir bag. In children suspected of choking, a spontaneous cough is the most effective method of relieving an obstruction. We allow them to cough and we support and reassess. When coughing is ineffective, immediate active intervention is required according to the algorithm. That brings us to the end of Module 2. So now please go ahead and do page 24 and 25 of your manual, which is the self-assessment questions, so that you can know if you understood the module or not. Thank you very much.